Welcome. This video contains vital information about the pediatric MMR vaccine. It was developed for healthcare providers working at Indian Health Service, tribally run, and urban Indian healthcare facilities. My name is Dr. Jasmine Curry Thomas. I am a member of the Navajo Nation and resident in family medicine, and I am partnering with Native Boost to bring this presentation to you today. For those of you who may not be aware, Native Boost is the project at the Northwest Portland Area Indian Health Board dedicated to sharing accurate, high-quality childhood vaccination resources with Native people and their medical providers. To access Native Boost's patient education tools, you can visit www.nativehealthresources.com, click on the Resources tab, and filter by the Native Boost campaign. Okay, let's get started. Today we will discuss information about measles, mumps, and rubella, the MMR vaccine, and current vaccination recommendations for children and infants. I will also share useful talking points you can use when speaking with parents and caregivers. Finally, I'll offer some additional resources. Let's take a few minutes to discuss measles, mumps, and rubella. Measles is a viral illness characterized by a prodrome of cough, coryza, conjunctivitis, and high fever ranging from 103 to 105 degrees Fahrenheit, lasting 2 to 4 days. This is followed by a maculopapular rash 2 to 4 days after the onset of fever, beginning at the hairline and face and then spreading to the torso and extremities. The rash begins as small, discrete spots but can coalesce to cover large areas. The rash lasts 5 to 6 days, then fades in the same order as it appeared, with spots peeling off in fine scales. Viral replication occurs in the lungs and lymphoid tissue. Measles is one of the most infectious diseases known today and can be spread person to person by large respiratory droplets. It is also capable of airborne spread by small aerolized respiratory droplets of less than 5 microns in size that can be suspended in the air for up to 2 hours. Measles is communicable until 4 days after the onset of illness. Humans are the only reservoir host. In the U.S., about 30% of measles cases will develop one or more complications. This is more common in children under 5 and it can include diarrhea, otitis media, pneumonia, encephalitis, subacute sclerosing panencephalitis, and then rarely death. About 3 out of 4 of all measles deaths occur in children in less developed countries where malnutrition and vitamin A deficiency are more common. Mumps is a viral infection that begins with a prodrome of fever, malaise, headache, and myalgia. Parotitis, or swelling of the parotid gland, can be unilateral or bilateral and lasts about 5 days. Subclinical cases are common and can also transmit infection. Mumps virus replicates in the nasopharynx and lymph tissue. Mumps is transmitted by both respiratory droplets and saliva. Patients can transmit infection to others 2 to 5 days from onset of parotitis in symptomatic cases. Notably, humans are the only reservoir host for mumps virus. Complications of mumps include inflammation of reproductive organs, including orchitis in people with testicles and ophoritis in people with ovaries. Complications also include inflammation of glandular tissue other than the parotids, including mastitis and pancreatitis. Neurologic complication of mumps can include meningitis, encephalitis, and hearing loss. Complications are more common in unvaccinated persons and in adolescents and adults, with orchitis, ophoritis, and mastitis being more common in unvaccinated post-pubertal cases. Rubella is a viral respiratory illness. In children, rash is the first presenting symptom. In adults, an initial prodrome of fever, malaise, lymphadenopathy, and upper respiratory symptoms occur 1 to 5 days before onset of rash. The rubella rash is maculopapular, less pronounced than measles, and does not coalesce. The rash lasts about 3 days and can be pruritic. Arthritis occurs more commonly in adults whose sex was assigned as female at birth, lasting up to 1 month and primarily affecting the fingers, wrists, and knees. Rubella virus replicates in the nasopharynx and lymphoid tissue and is transmitted by respiratory droplets. The infection is communicable from 7 days before to 7 days after onset of rash. Humans are the only reservoir. Complications of rubella infection are rare and include encephalitis, 1 in 6,000 cases, and thrombocytopenic purpura, 1 in 3,000 cases. Rubella infection can result in congenital rubella syndrome or CRS. CRS occurs when a susceptible pregnant person is infected, particularly during the first 12 weeks of gestation. Infection can lead to miscarriage, stillbirth, and birth defects, which include deafness, eye abnormalities such as cataracts, glaucoma, retinopathy, and microphthalmia, and congenital heart disease. Prevention of CRS through vaccination prior to pregnancy has decreased cases in the U.S. from an average of about 150 cases annually to less than 1 case annually. Now let's take a moment to discuss the ins and outs of the MMR vaccine for infants and children. The current MMR vaccine, called MMR2, is a combination vaccine. MMR2 contains 3 live attenuated viruses: measles virus using the Edmonston Ender strain licensed in 1968, mumps virus using the Gerald B level strain licensed in 1967, and rubella virus using the Wistar RA27/3 strain licensed in 1969. Each 0.5 milliliter dose of the vaccine contains small amounts of sorbitol, sucrose, hydrolyzed gelatin, recombinant human albumin, fetal bovine serum, neomycin, which is an antibiotic, and other buffer and media ingredients. The MMR2 vaccine has no preservatives or adjuvants. MMRV is a combination of MMR and varicella vaccine. In clinical studies and ongoing safety monitoring, the MMRV vaccine showed the same immune response and safety profile as co-administration of each vaccine separately. MMRV is primarily recommended for the second MMR dose, but it can be used for the first MMR dose if parents and caregivers prefer. Studies conducted for licensure of the MMR vaccine demonstrated some common side effects in recipients, such as fever in 5 to 15% of recipients and rash in 5%. In adults whose sex was assigned female at birth receiving MMR vaccine, arthralgias and other joint symptoms were commonly seen in as many as 25% of recipients. Less common side effects include febrile seizures, with one febrile seizure occurring for every 3,000 to 4,000 doses, and anaphylactic reactions, which are rare, with between 8 to 14.4 occurrences per million doses. The MMR vaccine has similar rates of fever. In addition, it was found to cause one additional febrile seizure in children aged 12 through 23 months for every 2,300 to 2,600 doses given, compared to those who received MMR without the varicella component. Levels of antibody response following vaccination of each component of MMR vaccine correlate with protection for each disease. Protective levels of antibodies can be found up to 13 years following primary vaccination for measles, 95 to 100% of recipients, mumps, 74 to 91% of recipients, and rubella, 90 to 100% of recipients. Prior to vaccination, the U.S. reported about 500,000 cases and 500 deaths from measles per year. Vaccination has decreased cases by over 95%. Current outbreaks primarily involve either imported infections or under-immunized communities. Similarly, vaccination has led to 94% reduction in mumps cases from about 150,000 cases annually in the U.S. to 9,000 or fewer. Mumps outbreaks continue to occur among adolescents and college students. Rubella cases in the U.S. have also dropped dramatically since vaccination began in 1969. Since 2012, all cases in the U.S. have been imported, resulting from infection that began while living or traveling outside the U.S. Since the adoption of a 2-dose MMR vaccine in 1989, the U.S. has achieved endemic elimination of both measles in 2000 and rubella in 2004. Recent measles outbreaks among unimmunized children could lead to a loss of endemic measles elimination status for the U.S. In 1998, Andrew Wakefield reported an association between MMR vaccine and autism spectrum disorder in a case series of 12 children. The published report was later retracted when further reviews showed that the report was not only critically biased, but included falsified information. In 2012, an Institute of Medicine literature review concluded that there was no evidence to support the plausibility of an association between MMR vaccine and autism spectrum disorder. When it comes to vaccine recommendations, to ensure vaccines are safe and effective, vaccine recommendations are continuously updated based on new information from disease surveillance systems like the National Notifiable Disease Surveillance System and the Active Bacterial Core Surveillance System. the Vaccine Adverse Events Reporting System, or VAERS, as well as the Food and Drug Administration, vaccine manufacturers, and independent researchers. The CDC Advisory Committee on Immunization Practices, or ACIP, is the body that reviews vaccine data and determines the recommendations published in the CDC Immunization Schedule. ACIP is a group of clinicians, researchers, public health experts, and at least one unaffiliated community member that meet at least 3 times per year. ACIP meetings are open to the public to increase transparency and public trust regarding vaccine recommendations. When it comes to MMR vaccine, the CDC immunization schedule recommends that MMR is given in a 2-dose series, with the first dose at age 12 to 15 months and the second dose at age 4 to 6 years. The vaccine is usually given as a subcutaneous injection, but it can be given intramuscularly with similar antibody response. Note that either MMR or MMRV may be administered, though for dose 1 in children aged 12 to 47 months, it is recommended to administer MMR and varicella vaccines separately. Catch-up vaccination for unvaccinated children and adolescents is also a 2-dose series, given at least 4 weeks apart. If MMRV is used, the minimal interval between MMRV doses is 3 months, and the maximum age for use of MMRV is 12 years. As with any vaccine or medication, severe allergic reactions such as anaphylaxis after a previous dose or to a vaccine component is a contraindication. Other contraindications include those that apply to other live virus vaccines and include severe immunodeficiency from any cause, pregnancy, and a family history of altered immunocompetence unless verified clinically or by laboratory testing as immunocompetent. For MMRV, HIV infection of any severity is also a contraindication. Precautions to be aware of before giving MMRV vaccine include recipient of any antibody-containing blood product, history thrombocytopenia or thrombocytopenic purpura, need for tuberculin skin testing or interferon gamma release assay testing, and moderate or severe acute illness with or without fever. For MMRV vaccine, additional precautions include a personal family history of seizures of any etiology, simultaneous use of aspirin or aspirin-containing products, or receipt of specific antiviral medications within 24 hours of vaccination. You may have thought during this section on vaccine recommendations, wow, this is getting a little complicated. If only there was an app for that. Well, there is. The CDC Vaccine Schedule app is a great resource for MMR and other vaccine recommendations. It is available for download for free for both iPhone and Android phones. The app is continuously updated with the latest immunization schedules for children and adults. It also includes catch-up schedules for people who may be under-immunized, as well as the most recent information on vaccine precautions and contraindications. To recap thus far, we have discussed measles, mumps, and rubella diseases and MMR vaccines, as well as current vaccine recommendations for infants and children. Now we will discuss strategies for talking with parents and caregivers about MMR vaccines and vaccines in general. Notably, suggested approaches and talking points are based on research conducted by Native Boost. In 2024, Native Boost conducted 11 focus groups to gather the thoughts of tribal community members and healthcare providers and clinic staff in the Pacific Northwest. In the end, we spoke with over 58 providers representing 12 tribal and 2 urban clinics and over 44 tribal members from across the region. Through speaking with community members, we learned that they want to learn the basics about what the diseases are and why vaccines are important via face-to-face conversations with trusted medical providers. Thus, when educating parents and caregivers about measles, mumps, and rubella, it's important to take time to discuss what these infections are, as well as the potential consequences of not vaccinating against them. Something to keep in mind when speaking with Native patients is that it's vital to use clear and concise language and to avoid using medical or scientific jargon. During talking circles, many parents and caregivers expressed that they did not understand or relate to medical or scientific terminology. To avoid making their providers feel like they were being challenged, parents and caregivers commonly said they avoided asking questions about concepts or words that they did not understand. So as a provider working with Native people, when you use medical or scientific jargon, you are missing an opportunity to effectively communicate valuable information to your patients. When it comes to speaking with your patients about measles, mumps, and rubella, and the potential consequences of not vaccinating against them, consider saying something like this. Measles, mumps, and rubella are infections that spread easily. When a child gets measles, they have a high fever, cough, runny nose, and a full body rash. In addition to being very uncomfortable, measles can make it hard for your child to breathe. It can also cause seizures, irreversible brain damage, and death. Like measles, mumps can be very dangerous. Mumps usually cause painful swelling on your face and neck as well as flu-like symptoms. If it spreads, mumps can damage your child's reproductive organs and cause seizures. Rarely, measles can cause brain damage and hearing loss. Rubella, unlike measles and mumps, often causes mild symptoms in kids like rash and fever. But if rubella gets passed to a pregnant person, it can result in miscarriage or severe birth defects. Fortunately, we have vaccines that protect kids for a lifetime from measles, mumps, and rubella. Then consider letting parents and caregivers know just how effective MMR vaccines are by saying something like, I let all my patients know that MMR vaccines are effective. Most children who are fully vaccinated will be protected through childhood. And if your child gets vaccinated and then happens to get sick, which is unlikely, their illness will be mild. Based on Native Boost research, one of the topics Native parents and caregivers were frequently interested in was vaccine safety, particularly as it relates to Native people. To address parents and caregivers' concerns about MMR vaccine safety, make sure to let them know that since measles, mumps, and rubella can result in serious health issues, we have been regularly vaccinating kids against it in the U.S. since the early 1970s. Since the MMR vaccine was approved, millions of Americans have safely received the vaccine, including American Indians and Alaska Natives. Since so much has appeared in the news and on the internet about the MMR vaccine and autism, it is important to let parents and caregivers know that reports linking MMR vaccine to autism have been carefully evaluated. The consensus among medical providers, public health experts, and multiple oversight committees is that the MMR vaccine does not cause a child to develop autism. Make sure to remind your patients that serious reactions are uncommon by saying something like, if you feel hesitant about vaccinating, keep in mind that serious reactions to vaccines like the MMR vaccine are extremely rare. You're more likely to get hit by lightning than have a severe allergic reaction to any vaccine. Based on Native Boost research, it is important to normalize mild vaccine side effects. Make sure to emphasize that after receiving the MMR vaccine, like any vaccine, children may experience mild side effects. Consider saying something like, when it comes to the MMR vaccine, common side effects may include fever or pain, redness or swelling where they got the shot. Mild side effects are a good sign that your child's body is preparing to fight measles, mumps, and rubella. Within our body, each of us have warrior cells, also called antibodies. They stand guard and attack disease. Vaccines like the MMR vaccine help our warrior cells see and fight disease. For example, when we get the MMR vaccine, the ingredients in the vaccine tell our warrior cells how to recognize and fight against measles, mumps, and rubella. Sometimes when our warrior cells are preparing to be able to fight, they cause mild side effects. These side effects are not a sign of illness. They are a sign that your child's body is getting prepared if needed to fight measles, mumps, and rubella in the future. Most mild side effects usually go away within a few days. If anything seems unusual or you are unsure, call the clinic. We can help. To summarize thus far, we have discussed the importance of educating parents and caregivers about the basics of measles, mumps, and rubella, including what these infections are, as well as the potential consequences of not vaccinating against them. Based on our research, we emphasize the need to use clear and concise language, void of medical and scientific jargon. We also offer language that can be used when discussing MMR vaccine effectiveness and safety, and the need to normalize the experience of mild vaccine side effects. Now we will discuss strategies for sharing culturally resonant messages with parents and caregivers that center a Native perspective. Something tribal community members said would encourage them to get their kids vaccinated when asked about effective messaging around vaccination. They commonly express the desire for providers to emphasize the benefits of vaccination from both an individual and community perspective. To do so, consider reminding parents and caregivers their responsibility to care for one another and generations yet to come. Finally, make sure you present information about vaccines in a way that honors parents and caregivers' autonomy and individual sovereignty. This includes providing information about vaccines in a non-judgmental, empathetic way that affirms parents and caregivers' experiences while sharing accurate information. As medical providers, it's critical to listen to patients' concerns, take time to share basic information about vaccines, answer questions, address myths, and accept that parents and caregivers have the power to determine the right choice for their child and family. To enhance your knowledge about measles, mumps, and rubella and other vaccine-preventable diseases, there are a few resources I'd like to share. First is the Epidemiology and Prevention of Vaccine-Preventable Diseases, also known as the CDC's Pink Book. This comprehensive manual provides detailed information about vaccine-preventable diseases and all vaccines on the CDC immunization schedule. The most recent edition was published in 2021. Since then, however, there have been changes made to the schedule. To ensure you have the most up-to-date information, make sure you check out the CDC 2025 Child Immunization Schedule. The CDC 2025 Child Immunization Schedule can be found on the CDC's website or accessed on the CDC Vaccine Schedules app. Finally, if you would like to access culturally resonant patient education materials offered by Native Boost, visit www.nativehealthresources.com. Also, check out www.indiancountryecho.org/boost for additional trainings for medical providers working at Indian Health Service, tribally run, and urban Indian healthcare facilities. Thank you for watching this presentation. Together, we can increase the number of Native kids who are protected against measles, mumps, and rubella, and other childhood illnesses.